So this is part 2 of 4 videos. If you didn't watch the previous video on general principles of stroke, pause the video right now, head over there. If you've completed that video, well done. Let's go and talk about ischemic stroke in this video. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at ischemic stroke. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Drop a like, drop a comment to Zambia and beyond, grab a piece of paper, and let's go. This is part 2 of 4 videos, so I will leave the previous video tagged at the end in case you haven't yet watched it and you just decided to just watch this one on ischemic stroke, so that you can head over there and actually watch that video so that this video makes much more sense. So remember from our previous video, we defined stroke as a syndrome of abrupt onset of non-convulsive focal neurologic deficit that's going to be resulting in sudden interruption of the blood supply to parts of the brain that's going to be lasting more than 24 hours. Remember, largely there are 2 types of strokes. We have what is known as an ischemic stroke, which is common in 80 to 90% of developed countries. It's often attributed to blockage of the blood supply either by an embolus or by a thrombus or by hypoxia. That's what we're going to be discussing mainly in this lecture. And then in the subsequent lecture, we're going to be talking about hemorrhagic stroke, which is accounting for about 10 to 20% of the cases in developed countries, though it has a much higher incidence in developing countries due to the fact that it is associated with hypertension. It may be in the background of primary intracranial hemorrhage, which may be intraparenchymal or intraventricular, or it could be extradural, subdural, or subarachnoid hemorrhage. So remember that when we talk about ischemic stroke, we have this sudden neurologic deficit that's going to be resulting in this localized area of ischemia, this focal cerebral ischemia that's going to be associated with permanent brain infarction, death of tissue. This is often giving you a positive result, and we can actually see this on a diffusion-weighted MRI. We can sometimes even see it on a CT scan. Remember that this is the most common type of stroke, accounting for 80 to 90% of the cases, and often it's going to be due to occlusion of blood flow to the brain. It's much more common in elderly patients, but we do have a few exceptions. And whenever you see a stroke, an ischemic stroke in a young individual, you should suspect 2 important conditions. One condition that you should suspect is sickle cell anemia. Another condition that you should suspect is rheumatic heart disease, especially if you see it in a young individual. Remember that the mortality rate is about 10 to 20% in the first week, which is quite low, though patients tend to die from complications about 1 to 2 months into the stroke. And these complications are often due to aspiration pneumonia, septic decubitus ulcers, and deep venous thrombosis. What are some of the causes? We largely divide them into 3 main groups. Thrombotic, which is by far the most common cause. It could be embolic or it could be hypoxic. So remember that in thrombotic, you're having a thrombus forming within the blood vessels in the brain. So there's having this narrowing, this stenosis of critical vessels, which is causing this local arterial obstruction. This is often usually related to atherosclerosis, but may also be associated with fibromuscular dysplasia. And often what we see with these patients that actually get this thrombi is that it usually happens when they're sleeping. So usually they'll present to you with symptoms when they wake up. So it should be like in a stepwise fashion, in a progressive manner. And often these patients have this previous history of having these transient ischemic attacks. Sometimes the thrombi can affect the large blood vessel. We call that as thromboembolic. For example, it can affect the internal carotid, or sometimes it can affect small vessels, which we call lacunar strokes. Remember that these are going to be penetrating. For example, if it's affecting the penetrating arteries of the branches of the basilar artery, then you can get these lacunar strokes, which can present with many features, which could either be purely sensory features or purely motor features. So they could have hemiparesis, they could have ataxia, they could have dysarthria, they could have numbness in the contralateral aspect of the face, the arm, and the legs. Or sometimes it could arise as part of an emboli. For example, if it's coming from the heart, where you have a cardiac emboli, arising from maybe an atrial fibrillation, you call that as cardioemboli. Then if it's arising from elsewhere, you call that as a thromboembolic phenomenon or an atheroembolic phenomenon, where you have dislodgement of a thrombus or dislodgement of a blood clot from outside the body. Now, before I go any further, I just want you to give you a hint. Remember that most of the thrombi are going to be forming in the venous system. So suppose someone has a DVT and you are in a question, in an exam setting, and they ask you, is it possible for someone to have a DVT and develop a stroke? Because remember that blood that's coming from the venous system is going to the heart and eventually has to go to the lungs first before it can circulate to the rest of the body. And remember that in the lungs you have these small blood vessels that can result in a pulmonary embolism. So why don't you have a pulmonary embolism and instead have a stroke in these patients? The answer is very simple. It doesn't make sense because you already know that if someone has a DVT, they're at risk of pulmonary embolism as opposed to a stroke. So this is kind of like what we call a paradoxical emboli, where someone has this blood clot that is being shunted across the heart. And if you get this type of person who has a DVT and eventually develops a stroke, you should suspect that they have a defect in the heart, maybe an arterial septal defect or a patent foramen ovale, because they have this shunting of the emboli from the right side to the left side. So you have this venous emboli that's being shunted from the venous side to the arterial side, thereby causing a stroke. So it is only in this scenario where you can have a paradoxical emboli in the background of a patient having a venous thromboembolism that results in a stroke as opposed to them having a pulmonary embolism. Now remember that these emboli usually occur in the extracranial vessels, and the extracranial thrombi can actually dislodge, they embolize, and then go and occlude large blood vessels inside the brain. You may also have embolism that's going to be occurring, and in these patients it's going to be occurring suddenly, and it's going to be occurring when the patient is awake. So most often it's going to be early in the morning. That's where they're going to be having this maximum defect at the onset. Sometimes you may get hypoxic cause. This is very common in infants, those that are suffering from hypoxic ischemic encephalopathy. We see that the features that it causes on the brain are very similar to what we see in stroke. So usually here, this will be in the background of patients that have systemic hypoperfusion or hypoxia, then leading to hypoxemia. This is very common in infants due to ischemia during birthing process, but it can also be seen in other things like septic shock as well as drowning. Now, what exactly is the pathophysiology of ischemic stroke? Remember here, whatever is causing the damage, whatever is causing the blockage, whether it's an emboli that has come from the heart or elsewhere in the venous system, or whether it's a thrombi that has actually formed in the blood vessels in the brain, there is a blockage. And remember that a blockage is going to be significant when at least it's obstructing more than 70% of the lumen. So whenever there is this inadequate blood flow to a single brain artery, remember that there is that circle of Willis that we talked about in the previous lecture, which is going to be providing this collateral system. So remember that there is some variations in the circle of Willis such that the size of the blood vessels actually differ. For example, if the thrombus or the atherosclerosis is affecting that large blood vessel in one of the variations, then it will cause much more disaster than if it were to affect the smaller blood vessels. So remember that the atherosclerosis and other acquired arterial lesions can actually interfere with the collateral flow, increasing the chance that the blockage of one artery will actually cause ischemia to the brain. Even though you do have these collaterals, you find out that the collaterals may not be of the same caliber as the blood vessel that has been blocked due to the different variations in the circle of Willis blood vessels. Now remember that once you have this blockage, then there's this compensation that's going to be taking place due to the circle of Willis to prevent this stroke. And if this compensation actually fails or a large blood vessel is blocked, then the tissues begin to die. Remember that time is brain. That's what we talk about in neurology. So some neurons actually will begin to die when the perfusion is less than 5% of the normal for more than 5 minutes. So time is brain. So if you have a mild damage that proceeds slowly, even if the perfusion is about 40% of the normal, if it's about 3 to 6 hours more than this time, then your brain tissue is going to be completely lost. It's going to be dead. If it's a severe ischemia, even as short as 15 to 30 minutes, then you have the brain tissue actually being dead or dying. And remember that the higher the body temperature, the faster the damage that you're going to see. That's why even in infants that actually have HIE, we want to perform what is known as therapeutic cooling to actually keep their brain at a lower temperature, because hypothermia is going to be slowing the damage that's going to be there as due to ischemic strokes. And remember that if this tissue the ischemia that you're causing to this tissue, it's largely going to be irreversible. But you may get sometimes some areas such that if you were to restore the blood flow, you may actually reduce or even reverse the injury. So sometimes you may get some areas of the brain tissue such that if there is intervention that is done, you can actually salvage these moderately ischemic areas. We call these moderately ischemic areas that can be salvaged as penumbras. And often these severe areas of severe ischemia, and the penumbras can actually exist because you have this collateral circulation due to the circle of Willis. Now, what is the mechanism of injury that we actually see when someone is having ischemia? There are certain things that can actually cause damage in the brain. One thing is this edema that's going to be there. And often this edema is going to be due to this release of this inflammatory mediators, interleukin-1b, tumor necrosis factor alpha, and this can actually contribute to the edema. It can also cause the microvascular thrombosis, which is worsening the damage that is being caused to the brain. And remember that if this edema is quite severe and quite extensive, it can actually result in an increase in the intracranial pressure. Now remember also that you are blocking blood supply to this organ. So it means that oxygen is not reaching, waste materials are accumulating in that area, and if oxygen is not reaching that area, these tissues begin to respire without oxygen, a type of respiration that's known as anaerobic respiration. Now remember that anaerobic respiration is not going to be producing enough ATP, enough energy as compared to aerobic respiration. Another thing that's going to be there is that lactic acid is going to be a product of anaerobic respiration. So this lactic acid can actually accumulate inside the cells and cause an intracellular acidosis, and the ATP stores are pretty much going to be depleted because you're not making as much ATP as possible. And remember, ATP is needed for the functioning of many channels. One such channel is the sodium potassium ATPase pump. Once that sodium potassium ATPase pump is not receiving enough energy, it means it's not going to be working to pump out those sodium ions that have accumulated within the cells. So it means the osmolarity inside the cells is going to increase. This is going to pull water into the cells, can cause swelling of the cells, and eventually it's going to be causing this damage. In addition to this, you have some reactive oxygen species that can be formed and can actually result in lipid peroxidation. So it can cause actually damage to cell membranes by formation of these free radicals. And remember, this is an ion-mediated process. You also do have a lot of excitatory neurotransmitters such as glutamate that are going to be produced. And because you also have this damage that is happening, a lot of calcium actually gets to accumulate within the cell, and this calcium actually can be the trigger for apoptosis. So these are all the different factors that are going to be contributing to the programmed cell death and eventually the death by necrosis and the extensive damage that we see in patients that actually present with ischemic type of stroke. So here's a picture of an ischemic stroke. Already alluded to this earlier on in the previous video. Remember that this is going to be darker than the brain tissue. So this is a person that actually had a middle-cerebral artery infarction. So as you can see, there is this low attenuation or this hypodensity that's going to be in the distribution of the right middle cerebral artery. Now, what are some of the clinical features? Remember that most of the clinical features that are common in stroke are going to be things like hemiparesis or hemiparalysis on one side of the body. You may have aphasia, difficulties in speech. You may have a patient actually coming in coma. And remember that the deficits are actually maximal within several minutes of onset, and this is typical of the embolic phenomenon, the embolic stroke. They can actually come in typically over a few minutes. And less often, the defect is actually going to evolve quite slowly over about 24 to 48 hours. So we call this as an evolving stroke or a stroke in evolution. This is very common in atherothrombotic strokes. And in most of these evolving strokes, you get this unilateral neurologic dysfunction that keeps progressing. For example, it may start off as one arm and then affect the leg eventually later on in the preceding days. Then, of course, it tends to extend without any headaches, without any pain or fever. The patient may have woken up just not being able to move their upper limb, and then later on you realize that they're not able to even move their lower limb. So this actually progresses in a stepwise fashion, and then you may even have some periods of stability in between. Then the stroke is actually going to be considered as submaximal when after it has completed its evolution, then you have this residual function that is retained in that affected area. So this suggests that maybe in the brain there is some tissue that is possibly viable and that you can actually salvage, that's actually capable of giving you this residual function even though the stroke has reached its maximum potential. Remember also that in the embolic strokes. These are often common during the day. Headaches may be a preceding symptom. Then with a thrombotic stroke, usually they tend to occur during the night, so they are first noticed when the patient actually wakes up. You may sometimes get a seizure on the onset of the stroke. This is much more common in the embolic strokes than it is in the thrombotic stroke. And sometimes you may even get seizures months, even years after this person has a stroke. Reason being that you may sometimes have the scarring in the brain tissue. You may sometimes have this hemosiderin that is depositing in the dead tissue inside the brain that can actually be leading to this seizures, and sometimes the seizures can be quite severe, and you may not even be able to control them with the routine anti-epileptic drugs. Deterioration during the first 48 to 72 hours after the onset of symptoms is particularly, like for example, if you have this progressive impairment of consciousness, this most likely is going to be attributed to the cerebral edema that's going to be there rather than the extension of the infarct. So unless you get a large infarct that's extensive, the function usually is going to be improving within the first few days, and then it will further improve until the person actually even reaches up to 1 year. So it means it's very important that you should start physio as early as possible. Headaches, coma, stupor, vomiting are actually much more common with hemorrhagic stroke than they are with ischemic stroke. Now, the specific features largely depend on the blood vessel that is blocked, which is why I emphasized on the previous video for you to understand the circle of Willis, the blood vessels which are involved in the circle of Willis, and the areas of the brain which they perfuse. Because once you are able to tell this, you can actually tell which blood vessel is actually being blocked based on the clinical features that you're going to be given on your exam. So common symptoms are going to be things like hemiparalysis, aphasia, and coma. And if it's affecting the anterior cerebral artery, this is not so common, but what you're going to be having is you're going to be having this paralysis or this weakness that's going to be affecting the opposite side of the body. So it means if the stroke is on the right hemisphere of the brain, the effects are going to be on the left side of the body. Because if you look at the descending motor pathways, they tend to actually cross over during the pathway. So the right side of the brain controls the left side of the body, the left side of the brain controls the right side of the body. So that's why you get this contralateral hemiplegia or hemiparesis. Remember, plegia means the paralysis. Paralysis means paraparesis, or paresis actually rather means this weakness. So remember, this is going to be affecting the legs more than the arms. You may also sometimes have confusion, you may have apathy, you may have urinary incontinence, you may have some primitive reflexes such as the grasp reflex, you may have poor judgment, because remember, judgment and intelligence are pretty much in the frontal lobe, which is supplied by the anterior cerebral artery. You may have mutism as well as gait hyperexia. If it's affecting the medial cerebral artery, which is most likely what you get on your exam, which is the most common cause of the ischemic strokes, you may have this contralateral affecting the opposite side, hemiplegia or hemiparesis. Now here it's going to be affecting the upper body more than the lower body. So it's going to be affecting the face and the arm more than it affects the legs. You may have this hemianesthesia. You may have aphasia if it's affecting the dominant hemisphere. You may have contralateral homonymous hemianopsia, which is this blindness on the opposite aspect of the visual field. Then you may have apyrexia, which is just uncoordinated movements. They're unable to even draw like a circle. They're unable to draw a clock. They're unable to draw a star. Then you may have this sensory neglect if it's affecting the non-dominant hemisphere. Then if it's affecting the posterior cerebral artery, you may get this thalamic syndromes with contralateral hemisensory disturbances. For example, contralateral homonymous hemianopsia. You may have this unilateral cortical blindness. You may have memory loss. You may have unilateral third nerve cranial palsies. You may have hemibalismus, which is pretty much this hyperkinetic involuntary movements that are going to be characterized by sudden, intermittent, violent, involuntary flinging, sometimes this ballistic high amplitude movements that are going to be involving the same arm and the leg on the same side. You may sometimes have it affecting the ophthalmic artery, which is a branch of the internal carotid artery. This is going to be causing blindness in that particular side of the body. You call this as ipsilateral monoocular blindness. If you see this, you call this as amaurosis fugax. Then you may have it affecting the cerebellum, where you have this vertigo, nystagmus, nausea, vomiting, ipsilateral incoordination. So if it's affecting the left cerebellar hemisphere, it's going to be manifestations in the system is going to be uncoordination on the left side of the body. You may sometimes have the lacunar strokes. Remember that these are going to be purely affecting the internal capsule. So they may cause you a pure type of hemiplegia, where you get this absence of cortical defects plus one of the following things, whether it's a pure motor hemiparesis or a pure sensory hemianesthesia or ataxic hemiparesis, or sometimes you may even have dysarthria or clumsy hand syndrome. You may sometimes get lacunar strokes where there is a blockage of the smaller perforating vessels into the brain parenchyma, and these ones are actually much more subtle and may present with only a few neurologic deficits, for example, a pure motor stroke or a pure sensory stroke, or sometimes ataxic hemiparesis. You may sometimes have it affecting the vertebrobasilar system, where you get this unilateral or sometimes bilateral cranial nerve defects, which may result in things like nystagmus, which is this jerky movements of the eyes, vertigo. You may have difficulty swallowing, which is dysphagia. You may have dysarthria, difficulty in pronunciation. You may have the double vision, that's the diplopia. You may have blindness. You may have truncal or even limb ataxia, which are these uncoordinated movements. You may have spastic paresis. You may have crossed sensory and motor defects. For example, you're going to be having this facial sensory loss on the same side, and then motor weakness is going to be on the opposite side of the body. Then you may have hemianesthesia or hemiparesis, which is going to be indicating a lesion that's going to be at the level of the pons or the medulla, tying into your physiology of the descending motor pathways. Then you may also have impairment of consciousness, because this is affecting the reticular activating system. You may sometimes have coma. You may sometimes have death if the basilar artery occlusion is actually complete. You may have tachycardia and labile blood pressures in these patients that are being affected with the vertebrobasilar system. Now, when you do your physical examination, remember you must carry out a full cardiovascular examination to look out for the rhythm of the heart, any murmurs that are present, any carotid or subclavian bruits, as well as signs for peripheral embolism, things like Janeway's lesions, things like splinter hemorrhages that could suggest an underlying cause. Make sure that you do a swallowing assessment as part of the clinical assessment of a stroke, because if they're not able to swallow, this puts them at risk of aspiration. Do a complete and thorough neurological examination. Now, how do you manage these patients? Remember, the key thing here is to distinguish between the different types of stroke, is to distinguish between hemorrhagic stroke and ischemic stroke, because the management is different. Imagine if you're treating someone for an ischemic stroke, the goal is to prevent them from having their blood clotting. Now, if you're giving them something that's going to be stopping the blood from clotting, and then imagine this patient has a hemorrhagic stroke, like potentially going to cause a disaster. So remember, if this patient has a transient ischemic attack, we should manage this aggressively. I will cover transient ischemic attack as part 4 of these videos, so please stay tuned and stay glued to the channel to see those videos. Then of course, management is going to be divided as general management, which is what we offer generally for most of our patients that come in with strokes, and specific management just specified for patients that come in with the ischemic stroke. It can be divided into acute management of stroke and long-term management of stroke. I do discuss both acute management of stroke and long-term management of stroke in this same particular lecture. So we'll begin with general management. Generally, this patient should be admitted to the ICU. Remember, this is considered as an emergency, so do your ABCs. Make sure that your airway is patent, so keep the bed elevated to prevent them from aspirating. Give them supplemental oxygen, especially if the saturations are less than 94%, because remember, hypoxia is going to be worsening neuron damage. Then you want to optimize their hydration and nutrition. Generally, fluid management by giving them the normal saline. That's if their BP is not raised. If their BP is raised, fluids are contraindicated. Avoid giving them glucose in their fluids unless if they are hypoglycemic, and we use a higher threshold of 4.4, but in our setting here, I've just seen it being used at a benchmark of 3 where I practice. Then the reason why we're avoiding glucose is, remember, glucose is neurotoxic, so we only give glucose if this person is hypoglycemic. Then we push in an NGT if the patient cannot swallow, and we've done our assessment. It's very easy. Just give them a little water to attempt to drink. If they choke, then obviously there's no swallowing reflex. If they're able to swallow just properly, then it's okay. The swallowing reflex is intact. Then we want to closely monitor the blood pressure and control any hyper or hypotension. We control the body temperature. Remember, we must keep them at a cooler temperature. So if there's a fever, if they have a temperature greater than 38, which occurs in about 44% of the patients which develop acute stroke, or if they have any infections, we treat the fever with paracetamol, acetaminophen, which we can give orally. We can also give it rectally, and in our case now, we can even still give it IV. Then we should provide them 4 to 6 hourly bed turning to prevent any decubitus ulcers, put a urinary catheter if they need a catheter, and start physiotherapy as early as possible. So it ideally should be started after 48 hours because it's a very important aspect of stroke management. It should be started early, and we should continue this physiotherapy for at least 2 to 3 months. There is some lifestyle modification that we often do. So we improve their diet in the long run, so they should decrease the salt in their diet. If they are overweight, they should lose weight. We encourage them to do some exercises within their limits. We encourage them to stop smoking and stop drinking. And if they were driving, they shouldn't be driving for at least 1 month. And then you come and reassess them if they're able to be fit to drive. So we should watch out for any signs of cerebral edema, any signs of elevated intracranial pressure, which are very common about 3 to 4 days after the stroke. Now, this is going to be evidenced by increase in intracranial pressure. So maybe their GCS, the Glasgow Coma Scale, is decreasing, or they're developing papilloedema. If you get any of these features, they even have projectile vomiting, then you can start them on mannitol, 20% mannitol, which is given intravenously at 5 mils per kg over 20 minutes. We can also give them intravenous or intramuscular corticosteroids 4 hourly, either our prednisolone 1 milligram per kg or our hydrocortisone 4 milligrams per kg. We should aim to treat the underlying cause. For example, if they have an atrial fibrillation, we give them warfarin. We aim to keep the international normalized ratio at 2 to 3. Then we start our low molecular weight heparin, and we transition them to warfarin to prevent skin necrosis and other bleeding. We should also give them diltiazem, which is a calcium channel blocker. This is specifically for patients with atrial fibrillation. Atrial fibrillation is another topic on its own, so we'll talk about details of it later on the channel. Now, what is the specific management of these patients? The first important thing is the blood pressure, and this is where most people potentially mess it up, especially for patients that have ischemic stroke. Remember that in patients that have ischemic stroke, cerebral autoregulation is damaged. The brain can no longer compensate for that drop in the perfusion pressure. It can no longer compensate for the drop in the blood that it's receiving. So in patients with ischemic stroke, if they have a high BP, not a very high BP, but if they have a high BP, we don't usually drop the BP because we carry out what is known as permissive hypertension, because this high blood pressure will keep perfusing the brain. And immediately you drop this blood pressure and you cause hypotension, then you're going to be causing more harm than good. So in all patients that come in with ischemic stroke, if the BP is less than 200 over 120, we don't drop the BP, at least for the first 48 hours. So we only drop the BP and we only give them treatment if it's an ischemic stroke that has a BP of greater than 200 over 120 millimeters of mercury, or if it's a hemorrhagic stroke that's greater than 180 over 130. Antihypertensives are actually much more important in hemorrhagic strokes than they are in ischemic strokes. So this is why you must always aim to get a CT as quick as possible, because it will have a bearing on your management. So reducing the BP actually quite quickly can actually worsen the symptoms. It can cause hyperperfusion injury and actually cause the stroke to even progress, which is why we don't usually lower the BP in the first 48 hours. So we have this permissive hypertension, unless if our BP is very severe. And what do we term as severe? Systolic BP greater than 200, diastolic BP greater than 120. Then we can lower the BP. We should do this preferably with short-acting antihypertensive drugs. This is preferred. Then in the long run, like for example, a week after the stroke, our goal is to reduce the BP below 140 over 90. So we can do this by using ACE inhibitors and other antihypertensive drugs. I talked about hypertension and the management of hypertension in another video that I will leave tagged at the end of this video. And remember that perfusion of an ischemic brain is dependent on this high blood pressure, like I said, because this autoregulation is lost. So if we actually drop the BP, then this will worsen things. There are only a certain number of scenarios where we do drop the BP. And what are these scenarios? If there is features of end organ damage, for example, aortic dissections, acute myocardial infarction, pulmonary edema, hypertensive encephalopathy, retinal hemorrhage, and acute renal failure, we do drop the BP. If the BP is greater than 200, some literature even say 220, or greater than 120 diastolic on 2 successive reading 15 minutes apart, then we do lower the BP. And we don't lower it quickly. We should lower it by at least 15% in 24 hours after the stroke. That's usually reasonable. But of course, you must be checking your mean arterial pressure and notice that it shouldn't be dropping very, very quickly. Then for the patients that are eligible for acute reperfusion therapy, which we'll talk about, except that they have a high BP, we can lower the BP. If it's in a setting where you're able to perform this acute reperfusion therapy, which we'll talk about later on, in most of our settings here, we don't do this acute reperfusion therapy, but in future, for future references, when we do start doing that in our setting here in Zambia, then you should actually consider this information, that you should lower the BP to less than 185/110. So this should be actually 110. So we should lower it by one of the following drugs. Labetalol is available in our environment. So 10 to 20 milligrams IV is a bolus over 1 to 2 minutes. We can repeat this one time. Then we can sometimes use nicardipine, 5 milligrams per hour infusion initially. Then the dose is increased by 2.4 milligrams every hour. Or 2.4 milligrams per hour every 5 to 15 minutes to a maximum of 15 milligrams per hour. So do not exceed 15 milligrams per hour. Clovidipine can also be used 1 to 2 milligrams per hour as an IV infusion. Then we titrate by doubling the dose every 2 to 5 minutes until we get the desired BP. And then we shouldn't exceed a maximum of 21 milligrams per hour. So these are the drugs that we can use. In our setting, we do use labetalol. Then patients that actually have presumed thrombi or even emboli, generally, we want to treat them with one of the following or a combination of the following. Antiplatelet drugs, which we do give in our setting. Anticoagulant drugs, which we sometimes give in our setting. And sometimes we can give a tissue plasminogen activator, which we rarely use in our setting. We can do thrombolysis in situ. We can sometimes even do mechanical thrombectomy, which we also rarely do in our setting. So, before we go any further, there's a scoring system that I want you to keep in mind. Remember, this scoring system actually gives you a risk of stroke within 2 days based on what we call the ABCD2 scoring. So, you give a point system if the patient has the following things. So, if the age is above 60, or if they're 60 and above, you give them a score of 1. If the blood pressure is systolic greater than 140, diastolic greater than 90, you give them a score of 1. Then clinically, if they show weakness, you give them a score of 2. If they have speech disturbance without weakness, you give them a score of 1. Then D is for the duration. If it's greater than 1 hour, you give them a score of 2. If it's within 10 to 59 minutes, you give them a score of 1. If it's less than 10 minutes, you give them a score of 0. If they have diabetes, you give them a score of 1. So if they get a score of 6 or 7, there's an 8% risk of stroke within 2 days. If they get a score of 4 to 5, there's a 4% of stroke, 4% risk of stroke. If they get a score of 0 to 3, there's a 1% chance of stroke. Now, what are these antiplatelet drugs that we give? Aspirin is one important drug. So aspirin, we can give it at a dose of 100 to 325 milligrams within 48 hours of the stroke. In some cases, in patients that we deem as high risk, those patients that have a TIA or those patients that have an ABCD2 score of 4 or above, which is what I talked about in the previous slide, or patients that have a mini stroke, we want to treat them aggressively. So we want to give them dual antiplatelet therapy if they have no contraindications to receiving this. So we often give them aspirin, the same dose of 100 to 325 milligrams orally, and then we also give them clopidogrel, which can give them a start dose of 300 to 600 milligrams orally as a start dose, and then we can give them 75 milligrams orally, and this should be within 24 hours of the stroke for all patients that are considered as high risk. And then remember that the aspirin, 100 to 150 milligrams daily, can be given for 30 days, and we only give this if we exclude hemorrhage. And we can only exclude hemorrhage by getting a CT scan. We can use other drugs. For example, if they are allergic to aspirin, we can use clopidogrel, we can use dipyridamole as substitutes. Clopidogrel is given at 75 milligrams orally once a day. And remember, aspirin given within the first 48 hours actually reduces the risk of early recurrent strokes. It reduces the risk of death. Some contraindication to antiplatelet therapy includes aspirin-induced or anti-inflammatory drug or NSAID-induced asthma or urticaria, other hypersensitivities to aspirin, or even tetrazine. You have acute GI bleeding if they have a history of glucose 6-phosphate dehydrogenase deficiency, or if they're using warfarin. These are all considered as contraindications to platelet use. Then if the patient actually has had a TIA or a mini stroke, clopidogrel with aspirin is actually given within 24 hours of the symptoms, and it's going to be continued for 21 days. Research actually showed that giving this for the first 21 days actually is much more effective than giving just aspirin alone in reducing the risk of stroke in the first 90 days. And this actually does not actually even increase the risk of hemorrhage. One would think that if you combine aspirin and clopidogrel, you may actually increase the risk of hemorrhage. But research has actually shown that the benefits greatly outweigh the risks. But however, if you go beyond 3 months, the use of clopidogrel actually plus aspirin has shown no added benefits, so we do not go beyond 3 months of giving both of these drugs. Beyond 3 months, we just continue on just a single drug. We continue on aspirin because there's a risk of bleeding the longer you actually use these drugs. And another mechanism, or another rather treatment that we do give, is anticoagulation. This is often done with either heparin, the unfractionated heparin, or you can do it with low molecular weight heparin. So this is if the stroke is actually caused by cerebrovenous thrombosis, or sometimes if the stroke is caused by a cervical artery dissection. Remember that anticoagulation can be used in patients that are at high risk of recurrent cardiac emboli, for example, those that have cardiac thrombi, or those that have mechanical valves. And remember this anticoagulation with warfarin for the patients with atrial fibrillation or a cardiac source of emboli. Our target INR is to get them at 2 to 3. So we can give heparin 500 units subcutaneous twice a day, or we can give clexane or enoxaparin, which is our low molecular weight heparin, at 40 milligrams once a day as subcutaneous. Remember that anticoagulation is generally avoided in the acute phase of a stroke because there is a high risk of you converting that ischemic stroke into a hemorrhagic stroke, especially if the infarct is large, which is why we generally don't anticoagulate our patients. In our setting, we just often would resort to just giving them aspirin. And remember that whether you're giving heparin, whether you're giving Coumadin or warfarin, whether you're giving antiplatelet therapy, remember this is not going to be working for the clots that have already formed. This is just going to be preventing the further clots from forming. So for the clots that have already formed, you want to perform thrombolysis, you want to perform thrombectomy, and actually this mechanical removal of these blood clots. So let's talk about thrombolysis. So remember that most patients that are not candidates for thrombolytic therapy should actually be given the aspirin, the antiplatelet drugs. That's our aspirin, 325 milligrams orally once a day once they're admitted to the hospital. And this is actually very, very strict, because if we use these drugs, these thrombolytic drugs, they have a very strict protocol and very strict indications and contraindications on which patients you can actually use them on. In our setting here, we rarely use them. And remember that these drugs like alteplase, which is a recombinant tissue plasminogen activator, is actually fatal and actually can cause symptomatic brain hemorrhage in patients that are treated with it. So it means that we should follow these strict protocols, and the reason being that there's a high risk of progression of the neurological function worsening. And so in patients that actually come in with stroke, usually this is only reserved for physicians that have used the drug before and those that have experience, because if it's a junior doctor that's actually using this, then it may actually cause brain hemorrhage, it may actually cause death. Remember that these recombinant tissue plasminogen activators are going to be used in patients that actually come in with an ischemic stroke and they have come in within 3 hours of the symptoms actually presenting, and they have no other contraindications to use of TPA. I'll talk about the contraindications of TPA, but some experts can even use a threshold of 4.5 hours, 4.5 hours after the onset of symptoms. But strictly speaking, it should be 3 hours after the onset of symptoms. So there is a checklist that the patient actually has to fit, such that they should tick all the boxes before you can actually use the TPA. In our setting, TPA is not routinely used. So if it's given incorrectly, for example, if a patient meets the exclusion criteria and you actually give them the TPA, there's a high risk that there may be hemorrhage happening in this patient who has a stroke, even if they do have an ischemic stroke. So if it's available, we can use it. So usually it's given in patients that present within 3 to 4.5 hours. Preferably it actually should be between 60 to 90 minutes. So if there's a large defect and there's no evidence of hemorrhage, or there's no other contraindication to lysis, then we can use TPA. What are some of the criteria that the patient must fit? Number 1, their systolic blood pressure should be less than 185 millimeters of mercury. Number 2, their diastolic blood pressure should be less than 110 millimeters of mercury. Their blood glucose must be greater than 2.8 millimoles per liter, and their BP, if it's not less than 180 over 105 for at least or rather, if it's not less than 185 over 110, it can actually be brought down with the hypertensives like nicardipine, IV labetalol, and IV clavitipine. And remember that we often give these antihypertensives to keep the BP low, less than 180 over 105 after we give the TPA, because if the BP remains high, there's a high chance of the blood vessels rupturing, there's a high chance of this person actually converting to it becoming hemorrhagic, which is why we continue on these hypertensives and keep the BP less than 180 over 105. So our dose of our TPA is going to be 0.9 milligrams per kg with a maximum dose of 90 milligrams. We give 10% of it as a rapid IV injection over 1 minute, then the remainder we give it as an infusion over 60 minutes. Then the vitals should be monitored closely for the first 24 hours and even 24 hours after the treatment. Then any bleeding complications are going to be aggressively managed. And remember, if you give a patient TPA, you shouldn't give them any anticoagulant or any antiplatelet drugs at least 24 hours after. So you should wait for at least 24 hours to elapse before you can give them any anticoagulants or any antiplatelets. Some contraindications to TPA use include anyone who's had a stroke or significant head trauma in the past 3 months, a arterial puncture which is in a non-compressible area in the past 7 days, anyone with acute internal bleeding or any acute trauma, if the INR is greater than 1.7, if they have elevated partial thromboblast in time, if they have thrombocytopenia, if they have uncontrolled hypertension, if their BP is greater than 185/110, if the glucose is less than 2.8 prior to intracranial hemorrhage or multilobar infarction, then you contraindicate the use of TPA. So it means that the patient must fit the criteria that I talked about previously and must not have any of these contraindications for you to be able to use TPA. So it's actually a strict thing that must actually even have a checklist for you to actually use the TPA. So sometimes we can perform thrombolysis in situ, where we do this angiographically directed intraarterial thrombolysis. So we actually dissolve the thrombi or we dissolve the clot. We can actually sometimes use this for the major strokes if the symptoms actually began less than 6 hours ago, particularly for those strokes that are due to large occlusion of the middle cerebral arteries, and in those patients that can't actually even use the IV recombinant tissue plasminogen activator. So remember that the clots in the basilar artery may be intraarterially lysed up to 12 hours after the stroke. So it's not just 6 hours. You may actually do this up to 12 hours, for example, in the basilar artery, and sometimes even later, depending on the clinical circumstance. This treatment, although it is considered as the standard of care in most of the stroke centers, it's often actually quite unavailable in most of the hospitals. Even here in our setting, not all the hospitals actually have this. I'm not even sure if any of the hospitals in our country actually do have this. Then you may sometimes perform mechanical thrombectomy, where you have this angiographically directed intra-arterial removal of this thrombi or this embolus by what we call a stent retrieving device. So this is actually the standard of care if someone has a large stroke and they are in a stroke center. And patients with recurrent large vessel occlusion in the anterior circulation actually can benefit from this mechanical thrombectomy, and it should not be used instead of IV recombinant TPA within 4.5 hours. So we can use TPA if there's no other contraindication for these patients that present within 4.5 hours. We shouldn't just resort to mechanical thrombectomy. Remember that devices used to remove these thrombi are being improved, and recent models are actually even much better and can actually even re-establish perfusion to about 90 to even 100% of all the patients. This mechanical thrombectomy can actually be used to treat patients who have had a severe stroke or those that have an NHI stroke score of 6 or more. You can actually just Google about the NHI stroke score and you actually read up more about it. And remember that with the mechanical thrombectomy, that has happened mechanical thrombectomy had previously been restricted to only patients that present within 6 hours of symptoms, but now you can actually do it in some patients that actually have presented much longer than this, because there is a substantial amount of tissue that can actually be salvaged, the penumbras that we talked about earlier on. And remember that the routine use of certain drugs in stroke patients actually doesn't limit neural damage. So use of drugs like corticosteroids, nimodipine, plasma volume expanders, barbiturates, streptokinase have actually proved to have no benefit in the patient and should actually be discouraged from being used. Long-term management, so supportive care, we want to control the hyperglycemia and the fever, because this actually limits the progression of the stroke, and this actually leads to better functional outcome and functional status. We want to screen for any dysphagia. So before the patient actually begins to eat, begins to drink, or receive any oral medication, as this is going to be increasing the risk of aspiration. So this should be done by ideally a speech-language pathologist or a trained healthcare practitioner. Then enteral nutrition, if needed, should be started within 7 hours of admission. We should prevent any DVTs by intermittent pneumatic compressions, especially for the patients that are immobile and don't have any contraindications to this. Then low molecular weight heparin can sometimes be given to patients that are immobile without any other contraindications. And we should also use some measures to prevent any decubitus ulcers, for example, 2-hourly, sometimes 4-hourly to 6-hourly bed turning, and we should start this as early as possible. Now, long-term management also is going to be including addressing certain risk factors such as hypertension, diabetes, smoking, alcoholism, dyslipidemias, and obesity. So we want to reduce the BP to a systolic blood pressure greater than 120 rather than the typical value of less than 140. This is actually much more effective and prevents the risk of restrokes happening. We cover them on a statin, so we can start them on simvastatin. Sometimes atorvastatin is one that's much more common in our setting. Simvastatin can be given 20 to 80 milligrams orally once a day. We cover them on a proton pump inhibitor, that's omeprazole, 20 milligrams orally once a day to prevent any stress ulcers, which are the Cushing's ulcers, from forming. Then we do also discharge them on oral antiplatelets. So remember that these are going to be used to prevent any subsequent non-cardioembolic, which can be due to atherothrombotic, lacuna, or even cryptogenic type of strokes. So we give this as what we call secondary prevention. So we can give aspirin 81 or 325 milligrams orally once a day, or alternatively, we can give clopidogrel 75 milligrams orally once a day. We can sometimes even give aspirin at 75 milligrams once a day. Sometimes a combination of aspirin at 25 milligrams with extended release dipyridamole 200 milligrams orally twice a day can be used. This is especially important for those patients that are at high risk. And remember, in patients that are taking warfarin, we do not want to give them aspirin or clopidogrel because this will increase the risk of them bleeding. Therefore, we avoid aspirin being given together with warfarin. Clopidogrel can be given as an alternative to patients that are allergic to aspirin or those that have contraindications to aspirin. And remember that if someone has an ischemic stroke that recurs, or a coronary artery stent that becomes blocked whilst they're taking clopidogrel, then they should actually be investigated for kind of like resistance to clopidogrel. Remember that clopidogrel is going to be metabolized into its active form by cytochrome P450 2C19 enzyme. So sometimes we can actually check the activity of this enzyme, and if we find out that the activity of this enzyme is reduced because of a certain mutation in the genetic material, then this can actually suggest that the metabolism of the clopidogrel is actually ineffective. So if you have impairment of metabolism that is confirmed, then aspirin or a combination of aspirin with extended release dipyridamole can be used as an alternative as opposed to clopidogrel. So in some patients we can give them clopidogrel and it's not really working because of this metabolism that's not being effective. Then remember that if clopidogrel plus aspirin is started during the acute treatment, then we should only use it for a short period of time, less than 3 months, because beyond this there's no added advantage and there's just a risk of more bleeding. Then clopidogrel plus aspirin before and for more than 30 days after the stenting is actually indicated, and usually we shouldn't exceed 6 months. And if the patient cannot tolerate, then clopidogrel. If the patient cannot tolerate clopidogrel, we can give them T-clopidine, which is about 250 milligrams orally twice a day as a substitute. Then we can sometimes give oral anticoagulant as a long-term therapy in some patients. It's indicated for those patients that have cardioembolic strokes. It's also indicated for primary prevention. So we do adjust the dose of warfarin. Remember that warfarin is a vitamin K antagonist, and our target here is to get our INR to 2 to 3, between 2 to 3, and it's used in certain patients who have non-valvular or valvular atrial fibrillation. So a target of 2.5 to 3.5 is used for those patients that have mechanical valves or those patients that have prosthetic valves. Remember that efficacious alternatives to warfarin for patients that have non-valvular atrial fibrillation include newer drugs. There are newer drugs that can now be used. These drugs can even be used in patients that have a DVT, such as dabigatran, which is a direct inhibitor of thrombin. We can give this at 150 milligrams orally twice a day in patients without severe renal failure. So you should ensure that the creatinine clearance is less than 15 mils per minute. And those that have liver failure, then this may be manifested by an increase in the INR. Apixaban can sometimes be used. Remember, apixaban is a direct activated factor 10 inhibitor. We can give it at 5 milligrams orally twice a day in patients who are over 80 years and in patients with a creatinine greater than 1.5 milligrams per deciliter or a creatinine clearance greater than 25 mils per minute. And this, as an alternative to aspirin, this can be given in those patients that can't take warfarin. Rivaroxaban, which is also another direct inhibitor of factor 10, can sometimes be used at 20 milligrams orally once a day, and this is in patients without any severe renal failure. Those that have a creatinine clearance of less than 15 mils per minute, it's contraindicated. We don't give rivaroxaban. So we must make sure that the creatinine clearance is at least greater than 15 mils per minute. Remember that these are new anticoagulants are actually easier to use, and you actually don't really need to be checking the levels of the INR or the anticoagulant other tests, and usually they can just be given as opposed to unfractionated heparin, which needs this continuous checking of the INR so that you can transition to the oral warfarin. The main disadvantage of this is that if there is an overdose, there is no antidote for this. So hemorrhage can actually occur such that there is no antidote. But there is an exception for dabigatran, which has an antidote, which is idraruzumab, which is this antibodies which can be given as an antidote. But we don't have this antidote in our setting here in Zambia. The efficacy and the safety of combining these newer anticoagulants has actually been questioned, and it's not yet been established because we do not have enough clinical data. Then we should also put them on statins to prevent any recurrent stroke, so the lipid levels must be decreased to a substantial level. Atorvastatin at 80 milligrams once a day is recommended, especially in patients that have evidence of atherosclerotic stroke, on patients that have a low density lipoprotein cholesterol levels greater than 100 milligrams per deciliter. Then a reasonable LDH cholesterol target is a 50% reduction or a level that's less than 70 milligrams per deciliter. Other statins like simvastatin, pravastatin can actually also be used, but in our setting, most commonly I've seen atorvastatin being used. Then there are some other mechanical or rather surgical interventions, quote-unquote surgical interventions that can be used as long-term management. One of them is extracranial carotid endarterectomy or stenting. So this is often indicated in those patients that have a recent non-disabling submaximal stroke that's going to be attributed to blockage of the ipsilateral carotid, which is between 70 to 99% of the arterial lumen, or someone that's had an ulcerated plaque if the life expectancy is at least more than 5 years. So in other symptomatic patients, like patients with a transient ischemic attack, endarterectomy or even stenting with antiplatelet therapy is actually indicated, especially if the obstruction of the carotid lumen is greater than 60%, whether they do have or they don't have ulceration, if their life expectancy is greater than 5 years. And remember that these procedures are often done by surgeons and the interventionists who have successfully recorded the procedure, and usually mortality and morbidity rates are less than 3%. That's why we usually do these procedures in these hospitals. If carotid stenosis is actually asymptomatic, then endarterectomy or stenting is actually beneficial only when it's done by a very experienced surgeon or interventionist, and because the benefit is likely to be small because already it's asymptomatic. So for most of the patients, carotid stenting with the emboli protection device, for example, a filter device, is actually done and is preferred over the endarterectomy. And this is particularly in patients that are less than 70 years and those that have a higher surgical risk. And carotid endarterectomy and stenting is actually equally effective for prevention of stroke. In the peri-procedural period, myocardial infarction is actually most likely after an endarterectomy, and recurrent stroke is more likely after the stenting. Then we may sometimes do extracranial vertebral angioplasty, and with or without stenting. This is usually used in certain patients that have recurrent symptoms of vertebral basilar ischemia despite optimal medical treatment, and they have a vertebral artery occlusion that's between 50 to 99%. We can carry out this procedure by the surgeons. And of course, they can do intracranial major artery angioplasty with or without stenting, which is considered as an investigational for patients who have recurrent strokes or TIA symptoms despite them having optical medical treatment, and they have an obstruction between 50 to 99%. In some cases, we may do endovascular closure of the patent foramen ovale, though this doesn't really appear to be much more effective for preventing the stroke than the medical management that we can carry out. But of course, certain studies and further studies are being carried out on the benefits of carrying out this procedure. Our prognosis generally during the first days, the progression and outcome can actually be very, very difficult to actually predict. The older the individual, the presence of impaired consciousness, aphasia, and brainstem signs usually are an indicator of poor prognosis. Early improvement in young age actually are going to be suggesting favorable prognosis, and about 50% that have moderate or severe hemiplegia, and most with milder defects actually have a clear sensorium, and eventually they can actually take care of their basic needs, and they can actually even walk adequately. Complete neurologic recovery usually occurs in about 10% of the patients, and the use of affected limb is usually limited, and most defects actually remain even after 1 year, and these are usually going to be termed as permanent. And if these patients actually who have had a stroke they are actually at higher risk of having a subsequent stroke, and it actually tends to even worsen the neurologic function. So if you find out that if someone actually has a re-stroke, they are actually much more likely to have worse symptoms and they're more likely to die. So about 25% of the patients who recover from a first stroke will actually have another stroke within about 5 years. And after an ischemic stroke, about 20% of the patients actually die in the hospital. And remember that mortality rates actually increase with age. Now here's a table that I explained in the previous slide, so I will not go into details of explaining it again. I'll just leave it on the slide here. You can actually pause the video, read through it. It's actually quite self-explanatory. It's a summary of everything I've been talking about. Same thing with the management algorithm that we've talked about. It's simply just the details of what I've been giving you in this previous lecture on the acute management of stroke and the long-term management of stroke. If you enjoyed this video, consider subscribing to the channel. Thank you for staying and actually paying attention through this long lecture. If you did enjoy, drop a like, drop a comment. To Zambia and beyond. See you in the next video. Until next time, my name is Moses Kazevu. Dr. Moses Kazevu, my bad. Bye-bye.